Him now for his presentation. Thanks.
Good afternoon. It's an absolute pleasure to be here. I'm not as smart as any of these people in this first table here, so I have a lot of pictures. Because I'm just a surgeon, right? No disclosures except for this is, I think, what me and some of my IBD surgeon colleagues try to practice, and best interest of the patient is the only interest to be considered. So quickly, brief introduction, how to decide on a surgery team. I think a surgery team is probably just as valuable as an individual surgeon. What surgeries are there for inflammatory bowel disease? We'll go over, which is kind of my passion, is really reoperative, or what they call corrective surgery, after someone's had an operation and maybe isn't doing as well as we would expect them to be. Are there things mechanically or technically that we can revise that kind of went awry that we can fix? What to expect from surgery, and then a conclusion. So just briefly about me, I did finish my training at NYU. I went to Cleveland Clinic for my colorectal fellowship. I went back to NYU and worked with a lot of these fine folks at this first table in the IBD Center. Went to Northwell and tried to start an IBD center there for the patients of Long Island, except for COVID kind of hindered that, and now I'm at Columbia really with a pre-established IBD team. I have a wife and 3 kids. Between them and my profession, that's all I care about. I used to be pretty cool. I put this in there for a reason. I used to play a lot. I mean, we recorded a few CDs. I learned all these instruments. I was an All-American lacrosse player. Believe me, that's not the case anymore. But I say that for a reason, because I think a lot of people are very nervous to see a surgeon. They picture maybe historically this stern person in a long white coat who's going to stand while you sit and is going to give you about 30 seconds to tell you how you feel. And then they're going to tell you, well, you're going to need surgery. Like, regardless of what you said. You could say, my car is just, I need to double park. Well, you're going to need surgery. And so I put that there because I'm not, in my opinion, and I think other surgeons who are IBD surgeons are not like regular surgeons. We're cool surgeons, right? We want to hear, and our appointments are much longer, and I'm usually there very late because we want to hear what your symptoms are. We want to hear how it's affecting your quality of life. And really, it's just a human being trying to help another human being who maybe has a little bit of experience in what is ailing them. And that's kind of the point. I would say the only difference with not being the cool former musician is when it's time to scrub in. Because when it's time to scrub in, it's every bit as serious as what you would expect. We're going for perfection, in my opinion. And I give my promise to the patients that they will have my undivided attention. I will not leave the room. In my opinion, with my background, if you went to see a violinist at Carnegie Hall and they just kind of hit a few wrong notes, unacceptable, right? I mean, you would never consider that a success. So with surgery, I consider the same thing. You have my humility that sometimes things don't heal the way we wanted them to go, and sometimes things are a little off, and sometimes it takes a little longer, but know that our heart is in the right spot, and we're going to do the absolute best we can to give their person their life back, to get them back to school, back to work, back to their partner, whatever the case may be. Because it's more than just a colorectal surgeon, right? You need all of this. This is a lot going on. You need the surgeon to be able to communicate with the gastroenterologist, probably most importantly, but the dietitians, the pathologists. I mean, there's a lot that goes into optimally taking care of a patient with inflammatory bowel disease. This is why I think, and this is my mentor, who I speak a lot, Feza Remzi, would talk about the idea of subspecialization. I mean, even in fellowship, you don't do that much inflammatory bowel disease per se, right? Because you're also learning how to treat patients with colorectal cancer. You're learning about more benign things, diverticulitis, hemorrhoids, things like that, and it's a quick year. So a lot of us have done extra, 1, 2, 3 years of training to really learn what it takes to properly care for patients. More than just the subspecialization, you need a team. And typically that ends up being at a major center, because those major centers have all of these at their disposal. Stoma therapy, let's just put that there. One of the things that we're seeing, unfortunately, more recently is patients coming too late for surgery. And some of that is just is the fear that, we're going to be waiting in the wings with a scalpel. And, again, regardless of what you say, you're going to the OR. So we want to see people when they're feeling good, maybe after they've, unfortunately, maybe progressed through their first biologic. I don't like to say failed. Progressed through the first biologic, and now they need to start a second. There's no emergency. Maybe just have a conversation, what can surgery offer? You'd be surprised, some people choose surgery. And I think most people, after meeting the proper surgeon, will choose timely surgery over being taken from their quality of life for an extended period of time. Slowly, they do less of what they love. It impacts them, it impacts their families. Now they're not, taking a semester off of college, and all of a sudden they're putting, I was going to travel to Europe and putting that back. If we could give you all that time back for a proper, timely surgery, which could be done minimally invasive, which is what we're doing a lot, robotically, laparoscopically. A lot of these incisions are very small. A lot of people going home within a few days. Not always, but that's the repetition of doing these things often, having these outcomes, the humility of being able to take on these cases and really giving your heart to the patient, and again, having the actual training to do this. So there's not many surgeries for IBD. This is it. Really just mostly colorectal. There's 1, 2, 3. There's like 7 things we do. There's really not that many. Some of them, strictureplasties, right? Little narrowings. And someone asked earlier, sometimes, and it's a paradox that the patient isn't that thin, and I mean this, they're not that thin, but they tell everyone, I can't eat. And everyone goes, what are you talking about? You look fine. The thing is, they can only eat high-calorie foods that aren't good for you. They can't have fruits and vegetables because they have a stricture. They have a narrowed portion. And that's what limits good quality food that keeps you full, that gives you nutrients. You end up eating things that kind of go right through you, that can go through that narrowed segment. So sometimes in that situation in the middle, you do a strictureplasty where you can open that segment up. You essentially make it twice as short, but twice as wide. Sometimes there's a long segment and you have to resect it. In Crohn's disease, sometimes it affects the colon. You take out the whole colon, sometimes just a piece. Sometimes it comes back or it's in 2 or more segments. It can get a little complicated, but really this is it. This is all there is. But clearly, there's something else, to being an IBD surgeon, right? There's this technical side. There's an art side. There's a craft side. There's that element of trying to be perfect. There's also the element of having the temperament to not just operate on everyone. When should we operate? Should we try this other biologic first? Should we try these 2 things? Let's try endoscopically if they could open that narrowing before we do any kind of surgery. But in case there's a problem, I'll be there in case that gastroenterologist needs, a rescue because they really tried to push the limit with the scope and maybe something happened. And then why are we operating? If you have some kind of mild stricture, but your quality of life is fine, you can do the things you want to do, maybe you don't need surgery right now. Right? The art of this all as a surgeon is thinking 2 and 3 steps ahead. That's the whole point of this. A lot of times, even colorectal surgeons, but especially, no offense to general surgeons, they're not thinking 2 and 3 steps ahead. They're doing something drastic, and it doesn't leave the patient better off. Surgically, going from these areas that are easy to the areas that are hard is the whole point, to save the hardest part for last. Because once you have freed everything up, and as my mentor would say, surround the enemy, that hard part isn't quite as hard anymore. And that's why you can push the limit and do things safely for patients. Now again, back to music. If there's only 6 surgeries that we're talking of, well, clearly there's something more to it than, which is a great song, Call Me Maybe, and catchy as can be. But clearly, if we're just talking about 12 notes, there's a difference to who's playing those notes between that and between this. So yes, you can have a bowel resection and there's 100 people that could do it, but they might be doing that. What you want is the person who's thinking 2 and 3 steps ahead. And that's kind of the point. So why operate for Crohn's disease? Unfortunately, we don't operate to cure Crohn's disease. We operate for the complications of Crohn's disease, such as bleeding, pain, obstruction, stricture, fistulae, God forbid, cancer. Right? That's why we're operating. But that's important because We know, unfortunately, sometimes they might need a repeat resection. So thinking 2 and 3 steps ahead and doing things to save bowel, to give them, to not resect as much as you need to save them possibly from another operation is very important. But unfortunately, it may recur. And if you need to have a recurrence, you need to be thinking 2 and 3 steps ahead. I think about one of my favorite poems, Robert Frost, who wrote it for his friend that I guess would have questioned which road he took regardless of which road he took. If he went to A, I should have went to B and vice versa. But I do think choosing the right surgeon with the right team can make all the difference. I really do believe that. Now, it's different for ulcerative colitis because ulcerative colitis, the idea, and we don't like, people say, oh, we're going to cure. I don't think they should say that. That's why I put it in quotes. I don't think that's really the case. But the idea is that we're going to cure the intestinal disease of ulcerative colitis. Now, it doesn't mean you might never need to see a doctor again. That does happen. But you still might need antibiotics. It could be years from now and all of a sudden things aren't going right and they say, actually, I think you have Crohn's. It wasn't ulcerative colitis. You might need additional procedures. That can be an abscess. You might have a stoma. We reverse the stoma. There could be a hernia. So I don't like the idea of saying, oh, we're just going to cure. You'll be fine. Let me just do this extremely complex J pouch and then you don't have to worry about it. It's not that. But at the same time, it is an opportunity to possibly avoid medications, especially for the GI symptoms. Now, they've done studies, it was Mayo Clinic. If someone does need their entire colon and their rectum removed for ulcerative colitis and they end up, for one reason or another, with an ileostomy, the quality of life is about the same compared to patients who have a pelvic pouch, such as a J pouch. But the idea, different than Crohn's disease, the idea is there's not going to be any more surgery and hopefully no more medications, knock on wood. Talking about reoperative surgery, there's a few things that happen. Someone has an operation for Crohn's disease. Maybe they're not doing as well as everyone would expect they would. There's some type of complication. Now, a lot of times it goes undiagnosed. The patient, we'll just give it another few more months. Your bowels are just kind of, they're waking up again. You go, I don't feel that well. Then they go, okay, we'll start some antibiotics. You still don't feel well, we'll give some CAT scans. Well, okay, fine, let's just admit you, we'll do the whole thing as an inpatient, we'll get an MRI, we'll get a scope. They get a PICC line, they get a clot from the PICC line, they get another IV. This goes on and on and on. Eventually they say, you know what, I don't know if this pain is real, why don't you speak to a psychiatrist? It happens. And then eventually they get transferred to an IBD center. Or there's some complication after surgery, and I've seen this, a lot of times it's no offense to general surgeon. There's some issue, there's some leak, there's something going on. All they need to do, which my mentor would say is the hardest thing to do, which is sometimes nothing at all. Just sit, just wait. And instead they go, I'm going to go in and I'm going to end up resecting all this bowel, things are inflamed, there's leaks, there's an enterocutaneous fistula. This is now a year or more of suffering this poor patient's going to have because someone decided to try to be, a hero and go back into the operating room, and eventually they get transferred to an IBD center. Or it's chronic. There's ongoing pain. The patient never felt right after surgery. They say, you know what? It's probably the disease. Crohn's probably came back, like it can come back in the recovery room. Right up, came back right away. Did it really come back right away? I would say probably not. Maybe not enough was resected, unfortunately. Or maybe there's something going on, maybe a small leak, and that small leak is causing this inflammation. You're having pain, you can't eat certain foods, and they go, let's try another biologic, which, and we'll do a course of steroids, which actually lowers your immune system, which is now the opposite thing of trying to fight the infection that your body was trying to do to begin with. And then what happens? An IBD center, right? When they really can't figure it out. So in my humble opinion, start at an IBD center, to be completely honest. Not that we're perfect, but we care. And if it's not perfect, we're going to keep trying until we can figure it out because we have the resources. One of the things that we see a lot is these connections, and this is not a human, I know everyone I didn't know I was right after lunch. And it happens both with Crohn's and ulcerative colitis. The ileostomy closure site after a J pouch, if there's an ileostomy, they close it stapled like this on the left side. It's quick. You could probably train a monkey to do it, honestly. It's quick, it's repeatable. Patients leave the hospital a day sooner, but there's problems with it. And if you can see on the bottom, on the right side, what happens when you staple it side to side is that you're cutting the circular muscle, which is supposed to propel things. And when you cut it open, it can't function like it should. So things have no problem getting in, but they can't get out. And you go to the hospital for a CAT scan, and they say, no obstruction. Everything looks open. The problem is it's too open. The problem is it's not, there's bacterial overgrowth. There's a partial chronic obstruction that no one diagnoses. And it happens in ulcerative colitis, and it surely happens in Crohn's disease, where that's extremely common. Now, what we do is hand sewn. It takes longer. It is what it is. My wife knows, put this, I'll be home later, let the kids eat. It's that important. Unfortunately, it's more important than seeing my kids every night. It's just that important. They'll be fine. I'll FaceTime them before I get in the car. But no one does this anymore. No, people don't learn this, and people don't want to take the time to do it. But it makes all the difference, because when you do it end to end, it heals like the God-given anatomy should. And thinking 2 and 3 steps ahead eventually, it actually, if there is a recurrence, saves the person maybe 15, 20 centimeters of bowel. And God forbid they need repeat operations, 5 times 20. They just lost 100 centimeters of bowel simply because the surgeon didn't take the time to hand sew it. They wanted slice and dice, as my mentor says, get in and get out. That's not the way to do things. After a J pouch, 95% of people, that's the kind of the number, sometimes it's 92, sometimes it's 98, but 95% of patients do very well. Some don't. Some have problems. If the patient is up for it, we believe they should have another shot. That one J pouch that didn't work, and then saying, well, it didn't work, you just need an endoleostomy. If that's their right, and if that's what they want, that's totally fine. That's what they should have. But if that's not what they want, and they want another shot, and there's a problem, maybe it's twisted that we can fix, then we believe they should have another shot. One of the issues that we keep seeing, this is where this line is. There should really be, remember, removing for ulcerative colitis the colon and the rectum, there should really be no rectum left. We leave about 2 centimeters because those last 2 centimeters have a lot of nerves. And that goes to your brain to sense when you have to go to the bathroom. So we like to leave those if we can. What we're seeing, though, is 5, 6 centimeters left. So there's still a rectum there. It's only about 15. So if you left half of it there, you can't say you cured that person of ulcerative colitis. What happens with that ongoing inflammation? Well, they have ongoing bleeding, ongoing pressure, urgency, pain, stricture they can get. A fistula they can get because that J pouch is connected to the rectum, which is inflamed, and everyone says, you know what, you must have not had ulcerative colitis. You probably had Crohn's disease. So we'll start the biologics. It should be straight. Blood supply goes straight down, the bowel goes with it, and it's connected straight. What we're seeing, though, is a twist. Very difficult, especially minimally invasive, to make sure everything is going straight because you're so close with the camera. There's a twist. Then what happens? Pain, bloating, can't go to the bathroom. Oh, maybe you need to see a psychiatrist because you just can't relax those muscles. Well, maybe it's not that at all. And then they say, you know what it probably is? It's probably Crohn's disease. Then they start the biologics. And this has led, not the gastroenterologist, has nothing wrong with giving the biologics. The patient sees the surgeon. The surgeon says, I'm perfect. That's how it works. God comes down and makes you a surgeon. How could it be me? It must be that you have Crohn's disease. So then they send this patient all packaged up to the gastroenterologist, and they say, well, it's nothing I did. That surgery went perfect. It's the best one I've ever done, actually. And then the gastroenterologist is seeing this poor patient in front of them, and they go, the only thing I guess we can do to decrease this inflammation is to start some type of medication. So it's surgeon-driven. It's not the gastroenterologist who are giving it out of nowhere. The surgeon is saying, there's nothing more I can do. Or there's a leak, and no one noticed it. There's a leak, there's a fistula, there's pain, maybe there's ongoing inflammation. I have chronic pouchitis. I can't seem to get off Flagyl. I take 250 ml every day. I can't seem, every time I stop it, it comes back. There might be a leak that no one diagnosed. Then what does everyone say? Fistula? It's probably Crohn's disease. It might not be, and we might be able to fix it if the patient wants us to go down that road of fixing it. One of the things that's a big difference between is it Crohn's disease or not is someone does well with a J pouch 5 to 10 years, they're doing well, all of a sudden they have a change in their symptoms. That might be Crohn's disease. And about 7% of the time, it can change its diagnosis. Doesn't mean you can't have a pouch with Crohn's disease, but we might need to add medication. It's a lot different than the patient, immediately has a complication, maybe after the first J pouch or after when their stoma was reversed. And all of a sudden, they say every time, no one coached them, I just never felt right. I never felt right after surgery. That is when we think maybe there is a twist, maybe they left the rectum, maybe there's a leak. And what my mentor and I found looking at this, out of all the patients that are referred for Crohn's disease of the pouch, and how I defined it for the article was someone put them on prednisone, someone put them on a biologic, someone was convinced this was Crohn's. Out of all of those patients, only 10% had Crohn's. The rest of them had some issue. Now, you can have a pouch with Crohn's, but you can't have a pouch with Crohn's and a twist. That's the kind of the point. So when we're looking at this for redoing some of these pouches, we look at the symptoms. Again, just listen to the patient. If it's less than a year, it's probably technical. Maybe it's something that happened in the OR. There's a whole, this is a lot. These pouchograms or gastrographin, you have to do an endoscopy. You really have to look at all the op notes. You look at the pathology, and you have to rule each one of these things out. This takes time. This takes resources, again, in IBD center. Quickly, about perianal disease. Very debilitating. About 20% of patients will only have this. It's a little more aggressive if you're young. It's a little more aggressive if you also have inflammation of the colon or in the rectum. It is very labor intensive. Typically, these procedures are not very complex, but they require repeat trips to the OR, placements of setons, drains, decreasing the amount of these drains, hopefully to have all these fistulas into one, and then you can fix that. We can do a flap. There's all these procedures, right? The success rate, unfortunately, isn't 100%. Luckily, we have a lot of people leading the way with stem cells. And stem cells, and you can see there's a few trials. The Admire trial is one of them. It's about up to 70% or over when it was only 50% on placebo. So we are getting there. I do think stem cells are the future. We're just, we're figuring out the timing, when to do them, how to do them, whatever's in that little jar. Again, I'm not that smart, but whatever, what's the combination? Again, it's really an art form, thinking 2 and 3 steps ahead, having your trusted gastroenterologist. In my opinion, having residents is excellent. Nurses, your OR staff, that's the team. That's who you need to trust to have safe surgery, to save bowel, to avoid a stoma if at all possible, and ultimately to avoid complications. Not lost on me is that someone in the operating room is someone's mother or someone's child or someone's grandpa. It's very important. And in my opinion, there's nothing else more important in the world, right? The whole world would just take just a breath and just realize how important taking care of each other is, taking care of the planet is, all these little things. You end up just having great outcomes if that's how you think. I don't know why it happens. It just does. But when you see a surgeon, you can ask. You're allowed to ask. We don't go, I can't believe that patient asked that, to the staff. What's your experience? Have you done a lot of these? Where'd you learn these? You can do that. Do you have a team? And then my mentor would say, out of all the 4 A's, they always talk about the 4 A's, available, affable, able. The most important one is accountable. And I didn't really understand what he meant until I was on my own, making the IBD center for Northwell and now at Columbia. Now I understand what he means, because this is imperfect. And at the end of the day, if things don't go the right way, the patient wants to know that you tried your best, and you need to be there to tell them that yourself, not how someone else will round. So accountability is probably the number one thing. In conclusion, your health means everything. Get second opinions. Don't feel embarrassed. Don't feel like you shouldn't. Get second opinions. But in my opinion, see a surgeon who specializes in IBD. There's the articles and the book chapters and things like that. And then there's the people who can roll up their sleeves and actually get it done. Ideally, you want that one person should be able to do both. Find a team who has things to support you. Make sure you go with someone with expertise and compassion. Ultimately, you meet someone, you like them, they have a great reputation, that they're great in the operating room. It makes me think of my favorite movie, sometimes you just know about a good melon, right? You meet a surgeon, you say, you know what, this is the person. I like this person. I trust them. Ultimately, just do not give up hope. That's all I can ask for. And thank you, and I probably went over, but any questions?